I'd like to share some of the predictors for the outcomes of COVID-19, which are very key in managing the patients that do present with COVID-19 infection. I'm Lloyd Mulenga. I'm from the Ministry of Health, and I practice at the BScHb Hospital in Zambia. I have no potential conflicts of interest in relation to this presentation. And one thing that we know so well, of course, are the definitions for COVID-19, which is a disease itself caused by the virus, SARS-CoV-2, which is a novel coronavirus. We have 7 human coronaviruses and 4 normal recorded previously, but we have the 3 novel ones. And the 3 novel ones are the MERS-CoV and the SARS-CoV and also the SARS-CoV-2, the one which causes the COVID-19 infection. When we look at the human coronaviruses, again, these are envelope positive stranded RNA viruses. Mentioned, of course, the novel ones, the SARS-CoV and also the MERS, and the SARS-CoV-2 are the one responsible for COVID-19 infection. We know that they do cause severe acute respiratory disease, and they're transmitted usually from cats for the severe COVID syndrome coronavirus, and also for camels for the Middle East respiratory syndrome, then possibly pangolins for the SARS-CoV-2. And when we look at these novel coronaviruses, we have to bear in mind that there are other viruses, other bacterial infections as well, which can cause the pneumonia. And when a patient does present, we need to look at other differentials as well. Should the patient also be evaluated for influenza? Certainly. For adenovirus? Certainly. But also for typical bacterial pneumonias like strep pneumonia, staph infections as well, Haemophilus. But we can also have other atypical pneumonias, pertussis, mycoplasma, chlamydia, especially in regions like where I'm coming from. We have a lot of atypical bacterial infections, especially in the HIV-infected population. So we have to look at it in a broader sense when we have a patient who presents with SARS-CoV-2. We know that the viral entry for SARS-CoV-2 is through the ACE2 inhibitors. These ACE2 inhibitors are largely found in the lungs, but are also found in other extrapulmonary sites like the kidneys, the lungs, and also we can have them in the GIT. As a reason, you have a widespread infection, and also you have a multisystemic involvement of this virus, and as a result affecting various organs and leading to various complications. Another thing which we also know is that these alveolar cells are the ones which have the highest burden of these ACE2 receptors, and as a result, primarily, that's why the lungs are the ones which are infected. But as I said earlier on, other organs can be affected, leading to disease once those organs are also affected. The primary symptoms, especially in the acute phase, the headache, the cough, sore throat, shortness of breath, fatigue, also have congestion or runny nose, and nausea, vomiting. But we need to also emphasize that the presentation does differ from one individual to the other, and also it does differ according to the age group as well. And we've seen a variation of presentations in different populations. Again, looking at the common symptoms which many of the patients do present with in terms of the frequency, cough, fever, shortness of breath, very common markers of the infection. But also we have one hallmark feature for many of the patients that do present, that is fatigue. Many people just have this excessive fatigue, but we have a minority of individuals who present with other rare events like they may have ear pain, conjunctivitis. And we've seen certain cases of individuals who do present are reliving with hemoptysis, but those are very few. So the symptoms have evolved over time as we've come to live with this virus. Because you have, again, the SC2 receptors widespread, and again, because of the systemic inflammation, which happens usually at endothelial level, you have manifestations of COVID-19 outside the lungs. You can have dermatological manifestations, cardiac manifestations, endocrine manifestations, and GIT. Neurological manifestations, especially headaches, are very, very common. Then you can have also events related to thrombotic episodes, and also the liver may be affected. And we see in certain individuals where the kidneys are affected. One thing, again, which especially in the acute phase, which you need to pay attention to, is the hyperglycemia, and some individuals may even present with decay. Fortunately, most of the individuals that do present with hyperglycemia post-COVID, they become glycemic. With disease progression, which is very key, again, for us to know when to intervene, and as later on a presentation is made on therapeutics, this slide is very important in trying to know which therapeutic interventions you have to give at which stage. So in the early stage, which is the viral response phase, that's where you have largely the mild constitutional symptoms. Then after that, you have the pulmonary phase, which is the stage 2. And there you have now symptoms related to the lungs being infiltrated. You have shortness of breath. Individuals become hypoxic. And this time when you do the chest x-rays, you may find imaging which shows abnormal infiltrates, especially in the lower lung fields. If you do CT scan as well, you may find infiltrations in the lungs as well. Procalcitonin, which is very key also to measure progression, is also usually in the lower side when someone is in the pulmonary phase. But as we said earlier on, that this is an inflammatory, severe inflammatory response, which leads to a cytokine storm, as most of these cytokines become increasing in numbers. Then you have now a high inflammatory marker response with a cytokine storm, and you have the ARDS, and this hyperinflammation phase usually is one which leads to most of the complications, and also mortality is high. So it's important to really look at an individual at which spectrum they are at for you to determine even certain interventions. Again, it's just the symptomatology on how one progresses from a symptomatic phase to mild illness, moderate illness, severe, and also being critical. With the viral replication being at the early stage, then you also have inflammatory responses coming in. And when you have the hyperinflammation stage, then you have someone having severe illness to critical illness. In terms of severity, WHO has simplified this now into just non-severe, severe, and also critical. When someone has no signs or symptoms of severe disease, then we just classify them as non-severe. And if the saturation levels start dropping below 90, respiratory rate is more than 30, then they become severely infected. In the children as well, the respiratory rate would be increased, and they start showing signs of severe respiratory distress. In the critical stage, they become septic, and also they have ARDS. NIH, of course, this is the classification used earlier on. We can look at asymptomatic mild illness, moderate disease to severe illness, and also critical illness. Usually it's just related on the symptomatology, especially the lung compromise, saturations, how they are, and also if someone's having respiratory failure and shock, being classified as having critical disease. When you look again at the cause in terms of the spectrum of disease, again, you see that most of the individuals that you lose, They have ARDS, which happens usually in the second week. Then once they start having organ involvement, acute cardiac or kidney injury, then mortality is increased. Similarly, when you look at the radiographic and also lab abnormalities, chest X-rays and also chest CTs, they do tell us much on how someone is going to present. And also, when we look at the lab markers, the D-dimers, the CRP, these are indicators of severe infection. Comorbidities are also common. Diabetes and hypertension is very common. Predictors of mortality, in hospital mortality, there are certain ones which you have when you have a patient in front of you. Just being male puts them at higher risk, hypertension at higher risk. But also if someone is dehydrated, have electrolyte imbalances, and also those that need invasive ventilation, even non-invasive ventilation, especially the elderly, these are predictors of in-hospital mortality. Similarly, again, obesity is another thing which you need to look out for. If someone is obese, then the risk of mortality becomes high, as high as 1.33 compared to those who are not obese. We did a study in Zambia. Again, HIV is very common, and we did not find HIV as being independently associated with worse outcomes. However, those that had uncontrolled HIV, they had worse outcomes. So if someone has a HIV treatment failure, then they're likely to have severe disease. Other markers have been used to predict survival as well, LDH, also the neutrophil to lymphocyte ratios. They are good prognostic markers for severe disease, hospitalization, and also intubation as well. CRP is also very key. Models have been used to predict severity, age above 70, then also other markers, interleukin-6 markers. We talked of the breathing rate as well. We have models to predict severity, certain models like the 4C mortality score looking at age, sex, comorbidities, respiratory rate, the saturations, Glasgow Coma Scale, urea, and CRP. And if you use these to grade into low, intermediate, and high, those who have high score, 4C mortality score, then that high risk, and these ones you need to intervene early and possibly send them into ICU. Other models as the HNC-LL score, this score is very popular, and we've given a formula there on how to calculate this. It looks at hypertension, neutrophil, lymphocyte, CRP, and LDH, and you can see CRP is coming out, including the lymphocyte count. And if someone has a high score, then the chance of them having severe disease and also mortality is high. The Mobster score is also another parameter, very simple here. Just consider another addition to bacterial co-infection, and also smoking. Hypertension also comes in, and this score would also predict severity. So the overall approach is that once you have a confirmed or suspected case, really evaluate. And once you evaluate, if they have intermediate to high risk, then you have to now move on and do imaging. And if the imaging shows that they have infiltrates all over, the scores which we have looked at, especially the HNC-LL score, is high risk, then admit to conventional COVID-19 unit. But those who are very high risk, they need to be admitted into ICU settings. This is the approach which I do recommend, and many people do recommend for individuals who present with SARS-CoV-2 infection. Thank you.